Good afternoon, everyone. As promised, we are back with yet another interesting episode of Expert Series. My name is Anugrah William, and I welcome you all to today's Expert Series session on antimicrobial resistance, guidelines, opportunities, and collaboration. Both domestically and globally, AMR is becoming more and more of a burden. According to WHO data, it is estimated that someone passes away from an infection brought on by a resistant bacterium every 45 seconds. Additionally, it has been estimated that bacterial AMR is responsible for about 12.7 million deaths worldwide. The amount is equal to the combined number of fatalities from malaria, HIV/AIDS. By 2050, it is predicted that AMR will be responsible for 10 million fatalities. AMR has major effects on animal welfare, the environment, food security, and poverty alleviation. In addition to this, negative effects on human health, 28 million people might be forced into extreme poverty annually by 2050. According to a World Bank projection, at a cost of US dollar 1 trillion annually to the global economy. To discuss the impact of AMR worldwide in detail, today we have organized a session on antimicrobial resistance, guidelines, opportunities, and collaboration. We are honored to have the august presence of Dr. Anup R. Warrior, lead consultant, infectious diseases, infection prevention, and antimicrobial stewardship, Aster DM Healthcare. Mr. Sharad Goswami, Senior Director for Global Policy and International Public Affairs, Pfizer Limited. Dr. Arpita Majumdar, Consultant Microbiologist, Molecular Microbiologist, Hospital Infection Control, Pathkind Diagnostics. Dr. Ravneet Kaur, Senior Microbiologist, SRL Diagnostics, Fortis Noida. And Mr. Bivash Chakravarti, who is also the moderator for the session, Head Regulatory Affairs, Quality and Government Affairs, South Asia, Biomerics India Private Limited. Before I hand it over to the moderator, I would like to make some housekeeping announcements. For our audience, please use the Q&A function on the bar at the bottom of your screen to type in your questions. The moderators will be able to see and address them. Please do mention whom your question is addressed to. So I would like to hand over now, Bivash, to you for taking the discussion forward. Thank you.
Thank you, Anugrah, and thanks for the introduction. And thanks to NATHEALTH for giving this opportunity. Little background, around a year back, since Biomerio is one of the key players into antimicrobial resistance, and we are a member of NATHEALTH. And NATHEALTH has a unique position of members from hospitals, from diagnostic laboratories, from medtech companies, startups. And at that time, Dr. Harsh Mahajan was the president. And I spoke to Dr. Harsh Mahajan that we would like NATHEALTH to take up this antimicrobial resistance as one of the key topics. Immediately, Dr. Harsh Mahajan has agreed, and he said it is close to my heart. Whatever needs to be done, we'll do it. And NATHEALTH has kept it as one of their key priority for 2022-2023. And we have been doing series of interaction with the key stakeholders, and we are trying to reach out to the various stakeholders. And today's webinar is also part of that. And we have esteemed panelists. We have a very balanced panelist, I would say. We have ID physician, Dr. Anup Warrior. We have two leading microbiologists from two leading hospitals and labs chain, who are also the key player. And last not the least, we have the leading pharma company, Pfizer, and Sharad is also here. So we have a very balanced panelist. And I do not know why Anugrah has pushed me that I should moderate this. There are more better people than me who could have moderated, but anyway, I'll take this challenge. So there will be no PowerPoint presentation today. So it is an open session, and it will be question and answer session. and all the participants can interact and can put their question on the chat, and we'll take this question as and when it comes. So I'd say a few words. What Anugrah has already covered most of it. There can be some repetition, but I would say what is antimicrobial resistance? Antimicrobial resistance is one of the major threats to global health, food security and development, and it threatens the effective prevention and treatment of infection caused by bacteria, pathogens, viruses, and funguses. About 700,000 people die each year from bacterial infection, according to WHO estimates. Antibiotics are supposed to save millions of lives, but today its pervasive use is leading to increase in resistance of these life-saving drugs. Factors such as overprescription of antibiotics, lack of awareness amongst patients to complete the dosage, overuse of antibiotics of livestock. And another area of concern is the absence of new antibiotics development, which makes it more difficult to overcome this issue. And as per WHO data, which Anugrah has already said, it has been estimated that every 45 seconds someone dies from infection caused by resistant bacteria. Also, it has been attributed that around 1.27 million people die because of bacterial AMR, and this number is equivalent to the deaths caused by HIV, AIDS, and malaria together. So there are estimates of 10 million deaths by 2050 due to AMR, which is huge. Antimicrobial stewardship is critical to fight the AMR, and AMS program helps fight antimicrobial resistance by providing a framework for responsible antibiotics prescribing and use, optimizing individual therapy, helping reduce the spread of resistance, and raising awareness and education. Successful antimicrobial stewardship program requires a continued and diligent interaction between all levels of healthcare providers, including physician, infectious disease specialist, infection control practitioners, nursing staffs, pharmacists, microbiologists, pathologists, lab directors, and healthcare administrators. I'll stop here, otherwise the panelists would have not much to say. So I'll stop here and I'll start with Sharad. So as Anugrah has already said, Sharad is the Senior Director of Global Policy and International Public Affairs of Pfizer. And all of us know Pfizer has been working on antimicrobial resistance very closely. So my first question, which is a little difficult question, I do not know, but and it has got two parts. The first part is, how will AMR have implication for not just the health of individual, but also for the healthcare system as well, and as well as for the other areas of the economy. This is the first part. And the second part is, what are the necessary steps to be taken? Sharad, over to you.
Thank you, Bivash, for the introduction and for the opportunity. I think the economic impact was already introduced at the beginning of the session, but as I was obviously looking through the topic, and we speak a lot on AMR at various forums. I'd love to point you to a report that I saw by Dr. Sita Lakshmi of the Pondicherry University, and she quotes several other reports. Right. And I wanted to start with just a few data points. They are alarming, but I think we do need to be alarmed if we need to, also in good conscience start working on this topic. All of us know about the Jim O'Neill report, which says 10 million lives globally by 2050. There is also a Frost report that says 2 million deaths in India by 2050 because of AMR. A very important aspect also, just to bring this alive for all of us, is really what's happened in the AMR space or the issue vis-a-vis the COVID-19 pandemic. And I can share two data points with you, which are again published in various reports. Right. The mean antibiotic usage for COVID-19 management in India was 74%. It's very while only about 17% patients actually tested positive for secondary infections. Right. So you can imagine the extent to which antibiotics and antimicrobials were used just during the pandemic. In fact, there is a tertiary hospital in India that reported an overall AMR rate to be about 84% in COVID patients who came in with secondary infections just in the months of April, June, and July in 2020. So not only do we have a raging pandemic, which is exactly what it is, it has been exacerbated and exaggerated post-COVID-19. So what we are dealing with now is going to have a huge impact on us in the times to come.
Right.
Clearly, there is need for action. There is a national action plan which has the 6 pillars, and we can go into those 6 pillars. But I feel that everything from the way antimicrobials are being manufactured and the guidelines around that, to the way that they are prescribed, to the way that they are consumed, to just the lack of awareness that today exists. And then, of course, to research and development for new agents and collaboration. I think these are all important aspects that need to be looked at if we are to tackle AMR in any serious and significant way. So those are just some introductory comments, and we can go a little into some of the work that Pfizer is doing when I speak next.
Yes. So exactly where you stop, I'll start from there. So what kind of contribution of company like Pfizer is making into antimicrobial resistance?
Sure. Many of you would be aware that Pfizer actually has a global surveillance program called Atlas, which is an open sourced program, which means any physician, any microbiologist, any infectious disease specialist can access that data and get a sense of what the resistance patterns are. We have a number of Atlas sites in India as well. So that's a lot of work that we do towards surveillance. Specifically in India, we have 3 very important programs that are currently underway. We have a partnership with the ICMR, which includes a awareness component. And I hope some of you, I think a year, maybe a little earlier than that, would have seen a big campaign that we actually ran.
Right.
I thought it was interestingly called AMR Ko Aao Milkar Roke. And we tried to raise awareness in the general public on what are the right and the wrong things to do.
Right.
Why self-medication, use of old antibiotics, not completing a course, not going by the doctor's advice. These are important factors that contribute. And then, of course, with ICMR as a part of the same project, we have a hub and spoke model where the ICMR hospitals are now hand-holding about 120 smaller hospitals through surveillance, through stewardship practices, data collection, upskilling, and that entire program is currently underway. We have another very interesting program called Parivartan. One of the insights that we had was that, from a clinician's perspective, the value of infection prevention and control and stewardship is well established. Clinicians understand this, and particularly clinicians who work within hospitals, who manage ICUs, they fully understand the importance. But what perhaps we need to do more is to get across to hospital managers, hospital owners, people who are involved in the functioning of the hospital. And if we are able to show them that when you introduce IPC practices, when you introduce stewardship practices, you actually improve outcomes that are relevant to a hospital manager or to a hospital owner. You reduce the number of days, you reduce the hospital-acquired infections, you reduce the consumption of antibiotics, the beds can be turned around faster. So we are implementing this program in 11 small hospitals, 50-bed, roughly sized hospitals.
As a pilot.
As a pilot. And we want to show, and we'll publish this once we get the outcomes. We want to show that there is a net positive impact on parameters that hospital administrators actually look at when these kinds of training and interventions are actually implemented. Lastly, of course, we'll talk about Open AMR, which is a program that we have created, which is a digital learning program for nurses. And this is available now in 7 languages. It's free of cost. Anybody can access this program. And it's based on the CDC curriculum. It's got 6 modules, and it gives you a certificate from Medvarsity at the end of this program. And that's a way to upskill nurses and nursing staff on infection prevention and control. So these are some of the initiatives that we are working on in the area of curbing AMR.
Great to know, Sharad. In fact, I was knowing that Pfizer is one of the key players in AMR, and Pfizer has been doing a lot of work, lot of awareness creation. But before this, I was not knowing that you have got such a wonderful program like ADNES, Parivartan. So these are eye opener for me. And globally also, you know that we are also doing point prevalence study. So Biomero is one of the key player into point prevalence study, and there are around 25 hospitals in India also participate into global PPS study, point prevalence study. I think great, Sharad. I think it is a great to know, and sometime we can talk offline to collaborate with Pfizer and Biomero and can join hands to do this. So this is also one of the opportunity. So as you said, I'll go to the next one. Can you brief us about the open AMR platform by Pfizer and how it is helping the frontline healthcare workers in controlling AMR? So you have already touched upon it. Maybe you have to expand it.
Sure. So, like I said, the whole idea here was that a lot of infection prevention and control is actually tasked to nursing staff and nurses in various hospitals. And while there are physical interventions that are done from time to time, this is the day of e-learning, and all of us have participated in e-learning type of concepts, and we find them to be actually impactful.
True.
So that was the one reason why we wanted to do this. The other was,
especially after COVID-19.
especially after COVID-19, the fact that today we are meeting like this, it shows the power of e-learning and e-engagement as a tool to expand reach. So that was the one driving factor. It also is a program that, like I said, provides you as a nursing assistant or as a nurse a certificate. So you get a certificate from Medvarsity that is something which is of value, and that also is something that motivates a lot of nurses to actually come and participate in this program. Right. It's a very good curriculum. It starts from the basics. It takes you through all the advanced concepts. Like I said, 7 languages. That was the other learning that we had. Right. That if we really want any program to be effective, it has to be in local Indian regional languages. Right. So we've already launched this in 7 languages, and we're seeing a lot of uptake. In fact, in just about 2 weeks, we have about 5,000 nurses who have already completed or signed up for this course, and many of them will start completing this very soon. We've got a great response, and in fact, even the hospital administrators welcome this kind of a concept because they see us kind of sharing the work that they themselves are doing with the nursing staff. Right. So we are hoping that this program will be successful, and we are rolling it out across the country.
Great to know. I think great learnings. And the last one, and this is a question.
Devash, sorry, just to intervene here. Yeah. I would request if, we take initial comments from all the speakers and then come to all the questions with first round of questions with the panelists. Maybe we would like to, take comments from Dr. Anup, then Dr. Arpita, and then come again to Sharad.
Okay, so so Sharad has already said his more than his opening comment, and maybe we'll now go to Dr. Anup. So Dr. Anup Warrior is the lead consultant for infectious disease and infection prevention and antimicrobial stewards in Aster DM Healthcare. And I think he's one of the key into this antimicrobial resistance. As an user, as a practitioner, I think his opening comments is the most welcome. Dr. Anup.
Thank you, Vivesh. So to start the discussion ongoing, I would only like to make 2 observations. The first observation is that in this panel, probably I am the only practicing sort of doctor who has a day-to-day interaction, who face the impact of AMR on a daily basis. And to those who are out there hearing this panel or who may hear this discussion later, what all statistics Anugrah and later what Sharath always told, I want to reiterate that they are not numbers. They are not just statistics. They are reality. We see them on a day-to-day basis. We lose people. We see neonatal sepsis with multi-drug resistant bugs, XDR, Klebsiella, switch, and we lose newborns.
True.
Just newborns who are just days old to the bugs which are not amenable to your regular antibiotics. So that's the first major point which I want to put out there. do not consider these to be some figures out there published by agencies or research or just existing in the journals. These are all realities, facts of life.
True.
The second thing which I want to put up here is that the focus when we look at antimicrobial stewardship, or you look at AMR perspective, and you try to address the part of antibiotic use or inappropriate prescriptions. Okay, the focus or understanding from the prescriber perspective is somehow not there. It always starts with a premise that the prescriber is silly. He doesn't know what he's doing, and that is the reason he is prescribing antibiotics left, right, and center.
Right.
That is a wrong perspective to take, and I have seen this in multiple forums, multiple things, etc. The starting premise is that the prescriber is uneducated. The prescriber doesn't know what he's doing. The prescriber does this because he is just silly and he doesn't know good medicine. But the fact of the matter is that there are certain key challenges or triggers or aspects which do put this prescriber into a spot. Okay, and while awareness etc. is a big thing, and education and knowledge is a big thing, it is not the only thing. So there are certain aspects which do put the prescriber into a spot. And moving forward, because there are only two major stakeholders here, it's the patient and the prescriber. The patient suffers, and it is the prescriber's pen who brings out the antibiotic. So you have to look at and address these two in a major way. So you need to look at the patient perspective and how to educate patients, how can patients participate in this whole AMR aspect, and you have to look at the prescriber from his viewpoint also, so that you get him alongside him and not trying to push him aside saying you don't know what you're trying to do, we will tell you how to manage stuff. These are the two important things I want to set it up here. Thank you.
No, very, very true, very true. Very correct. You have said your own experience, your own day-to-day life experience. So that's very true. So thanks for your comment, Dr. Anup. And moving on to the opening remarks from Dr. Orpita Majumdar. Dr. Orpita Majumdar is the consultant microbiologist of Pathfind Lab. So Pathfind Lab has got a chain of labs, and diagnostics lab is one of the major stakeholders. So over to Dr. Orpita, your opening comments.
Good evening, everyone, and thank you for giving me this opportunity to speak here on such an important topic of AMR. And to begin with, on this important thought my thoughts on this important topic is that I have a background of microbiology. I'm a microbiologist, and my primarily relationship with the bacteria is when the clinician gives me the sample. And just like Dr. Anup just mentioned, that they are seeing the cases, the patients, on a daily basis, how they are suffering. And these numbers that were just quoted are not just numbers, but they are the fact of life. Similarly, from the bacterial perspective, from sitting inside the lab, I have my day-to-day interaction with the pattern of the resistance of various bacteria is a very, very real, scary picture as a microbiologist, and that I can say. And definitely, as the clinician is facing the heat of this resistance and the negative outcome on the patient, here from the microbiologist point of view, there is hardly the situation is such that there is hardly in some isolates, there is hardly any support that the lab can provide to the clinician when they are seeing a completely pan-resistant isolate. They don't know what to do next. And even because of the limited options available, even we don't or we cannot provide them the adequate support. So, in my opinion, of course, awareness is definitely the number one thing that is required in this. However, as just Dr. Anup said, it is not about only focusing on the prescriber, but also on the general public, awareness in the general public. strengthening the diagnostic modalities that are available. Because let me tell you that though post-COVID, there has been a boom in the diagnostic industry, as we all are aware. But however, somehow the ground reality is that investment in good microbiology practices, starting from a good microbiology lab to hiring a good microbiologist or a microbiologist per se, good, bad is not, that's not relevant, is actually on the ground in our country a very minuscule number.
True.
So our focus, in order to help our clinicians who are fighting as the frontline warriors in the fight against AMR, the country per se needs to focus a lot on the diagnostics also, and provide all the as Sharad was saying, the hospital administrators, they should definitely take this thing much more seriously, in the sense that developing and strengthening their lab diagnosis is something that they need to understand. And in our country, considering that we have not only this problem is just not faced in a tertiary care center, but also in a primary care center in a 3-tier or 2-tier city. So the importance of having good diagnostic setup is extremely necessary and a need of an hour, because I think that is somewhere lacking. That is where hospital administrators, hospital management thinks that is where they can do a little bit of, take a back seat and try and invest in other places. So strengthening the diagnostics of the country is extremely important and very, very urgent requirement. That would be my initial comments on this.
Completely agree with Dr. Urpita. I think we work very closely with the microbiologists, and we know the pain points of microbiologists. And the microbiologists' work is no more limited with only culture and sensitivity. I think the role of microbiologists has really expanded. They are now working closely with the clinicians, with the hospital infection control program, and with the hospital infection and antibiotic policy. I think it is now, with the various tools available, now the role of microbiologists has really expanded. And I think the microbiologists like you, who understands the importance of antimicrobial resistance, can really play a key role. Thank you for your comments. And moving on to another leading microbiologist, Dr. Ravneet Kaur. She's the senior microbiologist of Fortis SRL lab, and she's also working into a hospital environment. And over to Dr. Ravneet.
Good afternoon. So first of all, thank you very much for giving me an opportunity to talk about this very pertinent topic, which is AMR. But a little thing which saddens me, and I'm sure other microbiologists, is that for many years we have been talking about this topic. It is actually time that now we move from table to actually bringing it to practice. So what happens is, like, I completely agree with Dr. Arpita that microbiologists are actually the need of the day, because they are the ones who understand microbes. They are the ones who can immediately raise an alarm that so and so bacteria is coming in huge numbers, maybe on the tendency of causing an outbreak, or this bacteria has become endemic now, and they actually know how a particular bacteria behaves. Right. So although as microbiologists and as the people working in close connect with clinicians, we are trying to do whatever we can do. Like, we are daily updating our clinicians about whatever is growing, and we are daily updating the concerned teams about MDROs, which are the multi-drug resistant organisms. And we are getting in touch with the clinical teams that please isolate this patient and do not allow this infection to spread from one patient to another. We are also having regular AMS CMEs at our setup. We are preparing antibiograms at least on an annual basis and regularly updating our clinicians. And as SRL labs in Fortis Healthcare, we have also come up with a concept which is not so common, which is calculation of DRI, which is drug resistance index. It is something like Sensex. Like, looking at it, you can immediately see that resistance in your unit is going up or down. For example, if the policy makers do not belong to the field of medicine, sometimes it's very difficult. It can become difficult for them to understand what is E. coli, what is Klebsiella, what is the resistance rate. But DRI, if it is more than 0.5, it can directly tell you that yes, your resistance level is very high. Above 1, there are hardly any options for your particular flora to get them treated by routine drugs. So we are calculating DRI, we are showing it to our policymakers, to our administrators, and we have also published some literature on it. But still, having said this, I still feel that this is not sufficient. Why? Because if I talk about our setup only, I'm here in this hospital for last about 12-13 years. And we have seen slowly resistance going up and up and up. And some years back, we hardly saw any MDR Klebsiellas or MDR Acinetobacters. But now as a routine, we are seeing them. And since we are in touch with, our other colleagues also from Delhi NCR, as well as in Punjab, Haryana also, we find that they are the common, the antibiogram more or less matches with, each other facility. So it's actually time that we now, move one step further, that what to do, how to bring clinicians to the meetings. So somehow I feel maybe they get too busy, or maybe somewhere, it's a little hard to drive in them that AMR is actually something which needs to be taken now very, very seriously. And again, I feel these CMEs should be done much more frequently, and learning should be shared with all. So a good start. Good start. That's all I can say.
Thank you, Dr. Ravneet. I think we had excellent comments from everyone. So thanks everyone for your opening remarks. And I'll now go back to Sharad. I think we have the last leg of the question. And Sharad, I'll ask this question, and which I think is a 3-part. I think it's a long question. And with AMR being such a big problem in India, how can the lack of innovation and therapies to treat superbug infection to be solved? This is the first one. Second, does India have an incentive system in place to welcome innovation into our country? Second. And the third part, if not, what incentive should India think of to encourage innovation on AMR?
Thank you. Very relevant questions, and coming from a pharmaceutical perspective, they are absolutely relevant to our industry.
Sure.
Here is a little fun fact. On an average, it takes about $1.5 to $2 billion
to get a new antibiotic,
to bring one drug from preclinical, pre-trial stage to an FDA-approved stage.
Sure.
Sometimes it's difficult for us to convert $1 billion into Indian rupees, but ballpark 8,000 crores. That's what it takes to bring one drug from an initial stage through the clinical trials, through FDA approval, and into the market.
And several years of
and of course, several years. And the other fun fact, for every one drug of any kind that gets approved, you start at the top of the funnel with about 5,000 to 10,000 candidates.
And it's very less in the bottom of the hill.
So 5,000 to 10,000 candidates preclinical lead to one drug that gets approved.
Yeah.
So the point I'm making is, whether it's antimicrobials or anti-cancer therapies or rare disease therapies, new drug discovery is extremely cost intensive, extremely high risk, unpredictable, and takes a fairly long time.
True.
That also means that we need to preserve what we have very, very carefully, because this pipeline is not very rich. This pipeline has a long gestation, and whatever we have today has to last longer. Otherwise, we are going to be in this kind of a dry desert where we are not going to have antimicrobials that are going to work. I mean, even the more advanced antimicrobials, we're now seeing the resistance patterns go up. So joint drug discovery, where the government and private sector partner together for agents of extreme interest, is certainly one way to go. I firmly believe that the investment in new drug discovery has to, will, and should come from the private sector, not from the government. World over, 70 to 80% of investments that go into new drug discovery don't come from government. They come from the private sector, which means we've got to make the environment such that it is attractive, conducive for private sector in India to invest in this high risk process.
Right.
What do I mean by that? And you may find this to be a little bit self-serving, but it is a fact. Pricing and price controls. One big factor that determine not just viability of a new drug, but in the case of antimicrobials, there is a very distinct linkage between when you cut prices, usage goes up indiscriminately, and therefore that becomes also a problem. So it's a very fine line to walk. Of course, we want access and affordability, and there are sophisticated tools to get access and affordability. But we also have to, in the way that we are drafting our price control policies, and that's what's happened actually this year. Right. You know, when the National List of Essential Medicines was developed this year, for the first time, and I'm so happy to see this, the experts had a separate consultation on AMR and how that has to impact and influence the drugs that get included in the National List of Essential.
For the first time, yeah.
For the very first time, which is absolutely what we should be doing. And I have two more points to come. The second, regulatory. We need to have a regulatory system. We should move in that direction, which is aligned to global regulatory systems.
Exactly right. Yeah.
Our regulatory system and India should be a part of the International Council for Harmonization. Right. What that does is it expedites the availability of new drugs, new antimicrobials in the country. We don't then have to face years of delay when a new antimicrobial agent is available to when it is available in India. And vice versa.
Without repeating the clinical trials in India.
New drug discovery from India can go to global. So I think these regulatory standards, harmonizing them with global standards, is going to make this pathway into an expressway. That's very important. Lastly, and again, this is something that we as an industry and innovative biopharmaceutical companies always talk about, is IPR. Intellectual property ecosystem has to be robust. Because like I said, if you are going to invest $2 billion, many number of years, what you want is that there has to be a robust IPR regime, because IPR is the lifeblood of innovation. Nobody is going to innovate if at the end of this entire process, there is an unpredictability as to whether patents are going to be granted, patents can be enforced. So that is a most important incentive. And if these three things come into place, the right pricing environment, the right regulatory environment, and robust IPR, believe me, there will be money coming in from private sector into new drug discovery, into new antimicrobials.
Agree.
The last thing I wanted to also mention, if I may not get a chance later, and we don't talk about this enough, which is immunization. Immunization, and particularly adult immunization, has such a strong and proven role to play, not just in curbing morbidity and mortality and economically, but AMR. Today, we have infectious diseases for which there is vaccine available, for which there is adult immunization available. And from our perspective, we talk about pneumonia, pneumococcal disease. Pneumococcal disease today can be prevented through not just pediatric vaccination, which is great because our country now has introduced pneumococcal vaccination as a part of the national immunization program. Right. But for adults and elderly who are that much more vulnerable, we must think of immunization not just as a public health intervention, but as an AMR intervention. And that is something that we must do. The one thing COVID-19 has done is that it has made people comfortable with the idea that adults and elderly and comorbids can actually take a vaccine. That mindset has never existed, but it exists now. Sure. Our infrastructure is in place, our delivery mechanisms are in place, our cold chains are in place. We must now use all of these capabilities and awareness that has been generated and purposefully look at adult immunization as also an AMR intervention.
Very, very true. Very well suggested. I hope Anugrah is taking a note of it, and I think we can add to it. I think this is one of the new dimensions what you said. So it was never discussed before. So thanks, Sharad. I think very beautiful points. So maybe if time permits, I'll come back to you. So let me quickly go to our next speaker, Dr. Anup Warrior. I think you had your excellent comments. So maybe I'll ask you a few questions related to your area. So AMR is a huge healthcare burden, and not just for in India but globally. How can India combat this issue? So when you say as a ID specialist, you know day in day out, and what are your suggestions?
Okay. So you have to classify this into two major categories. So you
Right.
have to understand that when you talk about resistance and resistance driven through antimicrobial use, the antimicrobial use has two categories. One is appropriate antibiotic use. A lot of antibiotic use is appropriate, and then
Yes.
you have inappropriate. We also have to look at ways and means to reduce antimicrobial use in its totality. And that's where this prevention aspect, what Dr. Sharath also was mentioning, comes up. Okay. So from the government sector and the public sector, what we hope will come in time is a very strong investment, thrust and focus on preventive health.
Yes.
There are a lot of ways how you can reduce the incidence of infections, starting from clean water and air, sanitation, public hygiene, which moves on to the other end of the spectrum, which is vaccination. So starting from your basic public health, safe water and hygiene in places, and ending up with individual vaccination. So this whole spectrum of preventive health has to be taken very seriously, and that is where the government should invest and put a lot of money, because that will pay out in the end.
True.
So it will reduce the overall need for prescriptions together. It will
Health
reduce
and wellness campaign. Health and wellness.
reduce incidence of hospitalization. If
Right.
people don't need to get into hospital so much, again the antimicrobial use comes down.
Yes.
The second part is about the inappropriate use, and that's where in my starting comments also I was mentioning that we need to look at what triggers this inappropriate use. And as I told you, it is not just awareness or lack of awareness or lack of education, because these are people who have studied 15-20 years and who are transplant surgeons, right? Or who spend 16 to 18 hours in the hospital in ICUs and managing critical use. It's not that they don't know or they don't understand the seriousness of this, so there are other aspects of this prescription. And of that, there are two key things, okay, which again from the policy perspective and all, which can be addressed, is one is that there is a diagnostic uncertainty in a lot of clinical interactions. Okay? Starting from when somebody with a cold and cough comes and sits in front of me in the outpatient, whether it is just an adenoviral thing, which I need not give anything to, whether it is H1N1 influenza or now COVID, and whether what is the risk of is going into secondary bacterial infection, what is the prophylactic role, should I empirically admit?
Right.
Each and every decision at a lot of this clinical interaction has got diagnostic uncertainty. And those diagnostic uncertainty can be addressed. It can be addressed not just by pushing in molecular tools, because molecular tools has a cost barrier and it has to be rationalized on how you introduce these molecular diagnostic tools.
Right.
It also has to be balanced by creating people who are confident of clinical diagnosis, right? So if somebody comes to me, the example which I mentioned earlier with cough and sore throat, instead of doing a 10,000 plus, instead of doing a panel on all viruses, influenza, COVID, etc., if I know that this is a low risk patient, I have a diagnostics confidence in this. Okay, this is a viral upper respiratory infection in a low risk individual. I can send him on symptomatic treatment of paracetamol and cetirizine. If I have that clinical confidence, I will not prescribe azithromycin. I'm not going to prescribe augmentin. I will not write ciprofloxacin. Okay. And this has to come from the training, from the medical colleges. And that's why I was mentioning about the policy part. You need to train better doctors who are confident in clinical medicine, who can make a diagnosis of upper respiratory infection, streptococcal throat, okay, so where there's a tropical fever. They need to have confidence in making syndromic diagnosis. And based on syndromic diagnosis, we need to rationalize, prioritize where we need to invest in diagnostics, advanced diagnostics, which will make a major difference both in patient outcome, therapeutic choices, etc. The last part of again this prescription thing, as I was mentioning, there are two stakeholders, right? The prescriber and the patient. Now, if the patient has to be aware and concerned Okay, and obviously only if the citizen is concerned, the government is going to prioritize. And for that, probably AMR deaths needs to be notifiable. It needs, just like how we are attacking TB. We are doing it in a great way. I'm proud that Kerala is one of the best performing states in this TB management control program. We have
Right.
excellent rates of notification and reporting facilities, and how we have streamlined or standardized certain management protocols. We have set up state medical boards for
Yes.
tuberculosis management, where if we have a confusion in a complicated case, drug-resistant TB, non-responding TB, there is a panel in the state which we send to, and they help us and support us.
Right.
So AMR needs to move into that space where the AMR deaths are notifiable, so that it pops up into the public domain. And then you have concerned citizens, and hence it's a priority for the government, and then the government should sit down and do something to act upon or reduce it.
Great insights. I think very well recommendation. I think we will take a note of it. And going to the next one, and what are the global case studies we can learn from, if you have any?
Okay, so we have some alignment and collaboration with the government of Netherlands, our state and my organization as an individual organization itself.
Right.
We do a lot of collaborative training programs, and we contribute to the European Society of Clinical Microbiology and ID stewardship education programs and all. And we were there in Netherlands and to study and understand. Why did I pick up Netherlands is that if you look at the data from Europe, Europe, you find all the both ends. You have towards Turkey, Spain, and this side where you have high drug resistant rates, Greece, Turkey, and that end of the Mediterranean, you have very high drug resistance rate. And even the other side of UK and all, still they have moderate or medium resistance. And then you have the Scandinavian countries, and especially even in that, Netherlands stands up as the country with the least drug resistance or AMR prevalence in the community. And so that's primarily, obviously, that means they have shown that something works, right? And
something good.
If you look at populations, and if you look at population density, you look at the worth or the economic stability, etc. There are other countries similar to them, like Germany and all in and around, even Sweden, etc. But even in those things, Netherlands still stands up as something which has least drug resistance rates. And when we were there, a couple of things which I took back from there is that they have a very structured AMS program in the government sector, starting from primary healthcare. So the stewardship program starts from primary healthcare, and they have obviously, like UK and all, they have a tiered system where the patient first approaches the primary care, then they have a referral up and up to secondary, tertiary, etc. So they're able to have a grip on the antimicrobial use over an oversight over the antimicrobial use as a system from the basic primary care itself, which for a country like India, you have to break it up into district or block level because compared to Netherlands and India, there is no comparison in terms of population or size, right? When I say that, yes, it's a model, but what they are doing is, as a country, probably we'll have to think of it doing it in a district, because that's how the population and thing is there. But that's something which is definitely worked for them. The second is about the culture and the medical regulatory framework around the culture. And I am specifically speaking about the end of life care and futility of care aspects. So there are publications, and even in my own hospital, I had done a survey and an audit, a clinical audit sort of thing, where the patients who are on end of life care or who are already, all of us know that the further care is futile in the ICUs, etc. The family and sometimes the treating physician is willing to withdraw renal replacement therapy, respiratory support, ionotropes or hemodynamic support, but they do not want to withdraw antibiotics. They say that dawa hai chalne do. It's a simple medicine, so let it continue. I mean, even the patient also, when they say that, when we explain the futility of care and go into this end of life care pattern, they also said that okay, don't do any interventions, don't start dialysis, don't put on a ventilator, but antibiotics, please give whatever the thing. And a tremendous amount of this high-end restricted group or your cholesterol, triglyceride, etc., a tremendous amount of these are actually put into these in this end of life care patients. And that's a cultural thing. And we have to educate the patient family and all also into this. So these are the, in Netherlands, they have complete control over this. The treating team, the medical team is who decides that who would benefit from aggressive antimicrobials or aggressive therapeutic choices.
Great example. I think great insights. I think thank you very much for sharing it. I think it was very, very useful. And I think there are two more questions is there. And more or less we have covered.
Vivash, maybe we would go to Dr. Arpita and Dr. Renuka because we have limited time. One question each, and then we can come back to Dr. Anu.
Okay, fine. So moving on to Dr. Arpita. So microbiologist, as in the opening comment, you said that there's a great role. So how can diagnostic labs play a role?
So I think the diagnostic labs have a very, very important role in AMR to play. Primarily because I will cite three important reasons why the diagnostics are important for AMR. First of all, the diagnostics, they play a critical role in preventing an overuse of antibiotics. If a strong diagnostic team is present, that can definitely support the clinician to decide the antibiotic policy that he wants to go ahead with that particular patient. So it will definitely reduce the overuse or the abuse of antibiotic. Also, the good microbiology lab, good diagnostic practices, good microbiology lab with advanced diagnostic modalities will help you to screen for antibiotic resistance patterns prevalent in that particular hospital or that particular area that it is catering for. And the diagnostics lab, through this practice, are the only source that can give you the data on the resistance patterns. So it is not only giving the data that is going to help the policymakers as well as the clinicians. It is going to tell us the trends. It is going to tell us whether there is a chance of an outbreak. So these, and hence action can be taken upon it. So these important information can come out only if there is a very strong diagnostic setup that is there supporting the clinician. So I think it is extremely important, and that's how we can help in this fight against.
Thank you. I think it is not only diagnostic setup, it is a microbiologist like you who are the key to this. Diagnostic setup can have biochemist, can have pathologist, can have histopathologist, hematologist, but microbiologist, as you mentioned and emphasized, is also key role. And I think the expanding of microbiologists of each hospitals and labs are very, very important.
Right.
Follow-up question, what you said is why promotion of judicious use of antibiotics is necessary and how it is going to help the arrest of the growth of AMR.
So when we say judicious use of the antibiotics, I think the first reaction or the first point that strikes us is just reduce the abuse of antibiotics. But in my opinion, judicious use is just not about reducing the abuse of antibiotics. It has to, it involves a lot of other important points that need to be taken when we are thinking about judicious use. First of all, the proper use of the antibiotics for bacterial infection only, and that can be available as I was just discussing if we have a strong diagnostic backup where the treatment can be optimized based on the proper severity, proper diagnosis and the severity of the infection. Also with the aim that there is maximum bacterial eradication happening.
Right.
With that treatment course. This would, along with the pattern that is prevalent in that particular area, your local prevalence of antibiotic resistance, because utilizing their data would be able to, with that data, we will be able to administer antibiotics in a manner that are not only cost effective, but also are more beneficial in the long run to the patient. So it's not just reducing the abuse or overuse of the antibiotics, but a culmination of all these aspects that is required for the judicious use of the antibiotics.
Totally agree. Long answer, but yes, it's right. So I had few more questions, but since there is not much time left, so I'll go to our speaker, Dr. Avneet Kaur. And the first question would be: there are a lot of government efforts in India on AMR, and if you can share a few key initiatives.
Yeah, hi, thank you. So talking about government efforts, there indeed have been a lot of efforts which have been taken by Indian government in last few years.
Right.
So if we talk about the past effort, there had been bucket of efforts in the form of RNTCP, which is Revised National TB Control Program, or we may talk about National Vector-Borne Disease Control Program or AIDS Control Program. But if we talk about the AMR, the efforts dedicated to AMR specifically, it started in 2012, which was in its 5-year plan by NCDC. NCDC launched a national program on the containment of AMR in its 5-year plan, which was from 2012 to 2017. So basically what they did was they established a surveillance system. that data would be collected from 30 different labs. As of now, there are 10 different labs which are, collecting this data and updating NCDC, and they are doing an analysis of the data. Then we had this program on which is known as AMR-SN, which is Anti-Microbial Resistance Surveillance Network, which was launched by ICMR. So what they did was they took data from 6 different labs, and gradually they extended it to 15 more hospitals. So we at Fortis Hospitals, we are also a part of it. So what we are doing is that we are manually entering our antimicrobial data on this portal, which ICMR is able to see on a real-time basis. And as a user, we can also analyze the data. So there have been publication also by ICMR on the same thing. Then ICMR also came up with ASPEC, which is Antibiotic Stewardship, Prevention and Control of Infection. So basically they did this study in collaboration with CMC Vellore. And before doing this, before launching this program, they thoroughly studied the practices in various private as well as government hospitals. And there had been some alarming findings. What they found was that although, infection practices were good, but there had been a lack of antibiotic stewardship programs. And they also found that private sector was doing much more better than government sector, which they attributed to the fact that probably it's there because accreditation is there by the private hospitals, which is not there by the government hospitals.
Right.
Now, if we talk about a very concrete step taken in this by Indian government, it was the launch of NAP, which is the National Action Plan in 2017. Which followed the GAP, which was Global Action Plan, which was launched in 2015 by World Health Assembly, where World Health Assembly had urged nations to come up with something on the similar lines. So talking about National Action Plan, which came up in 2017, I will just give you a very brief overview because time is short. So basically, there are 3 committees in this, which are one is an intersectoral committee which supervises the entire thing, then a technical group and a core working group. Now, 6 strategies are there in this. In the GAP, there were 5 strategies. India has come up with a 6th India-specific strategy. So the various strategies are creating awareness, doing surveillance, bringing down the antibiotic usage, investing more and more in this field, looking into infection prevention and control activities, and the last one, India-specific strategies, leadership, and strengthening this part of leadership. Now, lastly, I would in this first question, lastly, I would like to mention a very important area that there have been some very good changes which have occurred in the last few years. One was bringing the antibiotics in the Schedule H1. introducing Schedule H1 for few of antibiotics. So as of now, 24 antibiotics have been put up in this Schedule H1, this thing. These antibiotics are second and third generation cephalosporins, quinolones, as well as carbapenems. So basically, you need a prescription to buy these antibiotics. The pharmacy which is dispensing needs to make a separate register and entering the detail which the drug inspector is supposed to check.
Right.
And having a red label on this antibiotic.
Yes.
There have been some other changes like banning colistin as a growth promoter in animals, then banning some fixed drug combinations, which has happened very recently. And I think more would be included in that drug as we go on, and establishing antibiotic residual standards for the pharmaceutical industry. So I think these efforts have been very good, and it was really a need of the hour. And finally, we have woken up, and government has also listened to the policymakers and taken these steps.
Thank you, Dr. Avneet. I think I had a follow-up question, but you have covered everything. So in the first question issue, you have covered everything. So thank you everyone. I think 1 hour is not enough to discuss on this important topic. And Sharad was very smart that he covered whatever needs to say within the given time. So I know that we'll not get this. We'll have series of this kind of thing, and 1 hour is not enough. We just overshoot the time by 5 minutes. I leave it to Anugrah for the concluding remarks. I think thanks everyone. Great insights. I really enjoyed and I learned a lot of things. And as Dr. Ravneet says that I need to mention that RNTCP is now called NTEP, National TB Eradication Program. It's a new program. And it's an initiative by Prime Minister of India, TB Mukt Bharat, so TB Free India, Stop TB program by 2025, and everyone, all the central TB division, everyone is doing a great job, and I think the incidence of TB has gone down, and I think this is one of the great examples. So we have great insights and couple of very good recommendation, and I think Anugrah has taken a note of it. And over to Anugrah. So thanks everyone.
Thank you, Vivash. Thank you so much. And I think it was an interesting and a very insightful session. So with this, we are about to bring this expert series session into a closure. This event has brought together industry experts to help chart a way forward for antimicrobial resistance in the healthcare space. I would like to extend my heartfelt gratitude to Dr. Anu Parwarrier, Mr. Sharad Goswami, Dr. Arpita Majumdar, Dr. Ravneet Kaur, and Mr. Vivash Chakravarti for taking out time for today's session. Once again, thank you for joining us today and making this event a resounding success. I would like to thank NATHEALTH leadership team and secretariat for this guidance and support as well. And to our partners, AVNV and Healthwiz Insights for their support. This session is being recorded, and the recorded link will be provided to you shortly. And you can view the recording of this session if you have missed it on the YouTube and Facebook channels. Great. Thank you once again, and stay tuned for another session next week, same day, same time. Thank you once again, everyone.